Good morning, everybody. So my name is Kristine Garn. I am working for Helen Keller International, based out of Senegal, Dakar. I'm the Regional Nutrition Advisor and Coordinator for Africa, and happy to be here with you today and the last couple of days. Thank you. All right, so let's start by looking at some definitions. WHO defines adherence as the extent to which a person's behavior, for example, taking medication, corresponds with agreed recommendations from a healthcare provider. However, I find the definition offered in the journal quoted here in the slide to be more empowering and relevant for our discussion on adherence to MMS, as it puts the pregnant woman at the center of the service provision. And as you see, this definition also distinguish between adherence and compliance being the more passive behavior of following recommendations, and adherence being the more active process of empowering the patient to take responsibility for their own well-being. Now, looking at measurements, this is just a very sort of brief overview of some measurements methods for adherence. The first method listed is registration by medical providers, typically through recording of provision of MMS to pregnant women during ANC visits. Advantages of this method includes that data is routinely recorded and usually can be easily accessed through data registers. However, there is a risk of over-reporting, especially if the reporting of the data is linked with performance targets. Also, it is only a proxy for consumption, which can be set for all the measurement methods. The second method is record data by patient recall, which arguably is closer to capturing actual consumption, but is prone to recall baseline registration errors. Another option is pill count or weight, including using smart technologies that measures how often a pill bottle is opened and the change in weight before and after opening. The strength of this method is that it's directly observable and less prone to reporting error, but it doesn't account for pills lost or shared. Finally, there's the option of biochemical measurements, which offers a direct objective measure of the micronutrient levels, but this method is time-consuming, expensive, and complex, as micronutrient levels, as you all know, are influenced by a number of factors, including diet, bioavailability, and general health status. For Helen Keller, in the work we've done, in the studies we've done, we've used the first three measurement methods listed here. Excuse me. All right, so looking a bit on some of the implementation research that Helen Keller has been undertaking in both Africa and Asia, and I will be focusing in on the two studies done in Africa. And I would like to acknowledge the support, technical and financial support, that we have received from the Eleanor Crook Foundation and Vitamin Angels for this work. So in general, across these four studies, we looked at the following adherence-related questions, which were whether adherence to MMS is affected by the quantity of pills provided to the pregnant woman, the platform used for the provision, and the frequency of contact through ANC, which is the main contact for or platform for MMS provision in these four countries. Now, zooming in on the work we've done in Adamawa State in Nigeria, in this study we looked at health center ANC register data from an 8-month period covering more than 70,000 pregnant women. And what we observed was that the MMS was being provided at ANC visits in small plastic bags of 30 tablets. And as you can see, it was mixed with other medication. This was preventive malaria medication. And the reason for this was that it was building on the distribution logic on the existing IFA distribution model, which aims to encourage women to attend the 8 recommended ANC visits. So basically, women were told, come back every month for your ANC visit, we'll give you another 30 tablets. However, our analysis showed that only 11% of the women initiate ANC visits in the first trimester, leaving a significant gap in early engagement in ANC, which is crucial for completing the required 6 visits to receive the full course of 180 MMS tablets. Also, the average number of ANC visits in this group of women were only 2, which will obviously have consequences for the consumption of MMS, as a pregnant woman in average will only receive about 60 tablets during her pregnancy. Furthermore, as you can see in the photo, there is clear decoloration of the MMS, plus possibly changed taste, and the nutrient content can also be questionable with this practice of repackaging in small plastic bags. So, putting participation in at least 6 ANC visits as a condition for receiving the full recommended 180 MMS tablets does not allow women to take full responsibility of their well-being and the healthy growth of their baby through consumption of MMS, and ultimately lowers adherence. Now, continuing to the work we've done in Sierra Leone, I should mention that these results are preliminary, as the final research report is still being finalized. So here what we were looking at was a group of 533 women who were either currently pregnant or had delivered within the last 6 months. And the distribution of MMS tablets were done at one go, so women would be provided with 180 tablets during the first ANC visit. At least in theory, because in fact, around 12% of the health providers would provide less. So it's also just, even if we have protocols in place, thinking carefully of also looking at adherence to protocols of health providers is one thing that came out of this study. In summary, the results show a high levels of adherence, with almost all women having received MMS and about 89% of the pregnant women consuming MMS. Also, interestingly, 47% of the women were still consuming MMS after delivery, which suggests that women perceive the benefit of the supplement for their own health, and also might suggest that women start supplementation late in the pregnancy. In this study, unfortunately, we do not have data on the proportion of pregnant women having their first ANC visit during their first trimester of pregnancy, but national data from Sierra Leone suggests that the rate is about 45%. And the mean number of ANC visits in this study was about 5. The preferred platform for receiving MMS in this study were ANC visits, but interestingly, about 1/3 of the women interviewed thought that providing pregnant women with MMS tablets at the first ANC visit would actually discourage further visits, with the main reason being the long travel time. So there was a bit of discrepancy between actually observed practices and the perception of the women themselves. All right, so just some overall findings. It appears that provision of 180, so the full course, recommended course of MMS tablets at one contact, appears not to negatively affect ANC visit adherence. And these findings were supported by our work both in Sierra Leone and Cambodia. And adherence to MMS really seems to be high, which may be due to what we just heard from the previous speaker, high levels of acceptability, and the perception of MMS really bringing positive health effects and leading and fewer observed side effects. And these are also findings that we have confirmed in work we've done in Sierra Leone and Mali, which is an ongoing study. Finally, I just wanted to finish with a few key takeaways and next steps. So, In many African countries, women have their first ANC visit after the first trimester, which limits the benefit of MMS and other care. A meta-analysis of demographic and health surveys showed that only about 41% of women in sub-Saharan Africa have their first ANC visit during the first trimester of their pregnancy. Also, preliminary results from implementation research that we are undertaking in Mali shows that only about 44% of women are actually able to make decisions about attending ANC visits independently from their husband or larger family. Consequently, I argue that we must be careful with making access to MMS conditional on ANC attendance, which is the practice in some contexts, as it may effectively decrease access and adherence to MMS consumption. Also, depending on local context, specifically the coverage and quality of ANC services, additional platforms for MMS provision should be considered while working to strengthen ANC service provision. This could include distribution of MMS to pregnant women by community health workers, through campaigns, or even through private pharmacies. In short, we need to put pregnant women at the center of our MMS program and develop strategies to increase their access to MMS, including ensuring that they receive quality counseling by the health provider, together with support from their family and community. So again, it's interesting to see how these findings come together, reflecting back on the previous presenter on acceptability. It seems like, yeah, the results are very similar. Finally, I would like to finish by saying only then, with this increased access to MMS, will women be fully empowered to take responsibility for her and her baby's health. Thank you.